Hello, welcome to Cardia, Hearts and Sciences, the program dedicated to the understanding of the human heart. And like we say, we all have one, and the more we know about it, the better care we can take of it. And I'm with my host, Dr. Greg Mishkel, who also happens to be the Executive Medical Director of the Prairie Heart Institute. And we have a special guest. You want to take over?
Do I get to introduce him?
You get to introduce, yeah.
Dr. John Scherschel is an electrophysiologist, one of our newest colleagues, and an extraordinarily accomplished electrophysiologist. And we're going to learn a little bit about today how modern-day cardiology treats patients who have very severe symptomatic atrial fibrillation. And we're going to educate you about atrial fibrillation.
And I need it.
Okay.
I need it. Okay, not because I have it, but because
you don't want it.
Everybody needs to know. Right. That's right. Okay, Dr. Scherschel, thanks for being here.
Thank you.
Just a little background. How long have you been in Springfield?
Almost 2 years.
Almost 2 years. So you're kind of new.
I am.
You've seen. You're a young man, so you haven't seen a lot of changes. But you've come into this profession sort of at a time when things are changing rapidly, aren't they?
I explain it to patients that everything I'm doing is like cell phone technology. It changes, and by the time we get it in the hospital, it's obsolete, and we're looking for the next one.
Mm-hmm. And so you and your colleagues that are your age are probably really sort of, you're used to dealing with change. I mean, it's no big deal all the time, right? It's just ongoing.
Probably the greatest gift my mentors gave me was the idea that half of what I'm doing is wrong, and I don't get to know which half for 5 or 10 years.
Comforting thought.
It is, but it also puts you in the mode to learn, and everything I'm doing can be done better. And every tool I'm using may have a new iteration in just a few months or a year.
You know, electrophysiology is a real mouthful. Would you guys like to try to describe that, what that is?
Well, I'll take a crack at it first. So I've always talked about that in cardiology, there's plumbers and electricians. And plumbers deal with essentially the pipes or the pumping chamber of the heart. And the electricians deal with the electrical circuits in the heart. And the interesting thing about cardiology when I started was there were electricians, but they basically just sat around reading EKGs. They didn't really do a whole lot. Now, like a lot of cardiologists, electricians have become doers, and atrial fib, which was a condition which has been around for obviously time in memoriam, was a condition where we just essentially treated patients with medicines, and if they didn't get better with medicines, we just told them to take more medicines. And what John and his colleagues do is that they've figured out ways to get rid of atrial fibrillation.
Yeah, actually cure it. And that was something you
Do we use the word cure?
About.
I try not to, but
no?
Yes. We can eliminate the triggers that cause atrial fibrillation. And so in a sense, we provide what I tell patients is a clinical cure. A cure is harder to define because a cure means that the things that caused it are no longer there. And the factors that contribute to atrial fibrillation are many. The reasons patients have atrial fibrillation can be many. Several conditions can play into atrial fibrillation and cause it, but the underlying triggers that start episodes are easily identified and usually eliminated. So if someone has high blood pressure or sleep apnea or a congenital valve disease that causes atrial fibrillation, the cause is still there, but the trigger that starts episodes can be eliminated.
So what, in simple layman's term, because that's what Mark is,
Please.
both of those.
Right. What is atrial fibrillation?
What is atrial fibrillation?
Atrial fibrillation is an atrial arrhythmia, and many patients think about atrial fibrillation as irregularity of the heartbeat, and technically that is not entirely true. It's possible to have a perfectly normal pulse, but have atrial fibrillation. The upper chambers of the heart, the atria, are fibrillating or beating very, very rapidly, sometimes as fast as 1,200 times a minute, which is too fast to do anything mechanically useful. The lower chambers of the heart respond to atrial fibrillation and provide an irregular but usually more rapid than normal heartbeat. And so patients perceive atrial fibrillation as irregularity of the pulse, whereas as an electrician, I say, well, it doesn't matter what the lower chambers are doing, what the pumping chambers are doing. It's the upper chambers, the atria, beating very irregularly that causes or is the definition of atrial fibrillation. And that disconnect is difficult because if a patient has a pacemaker, for instance, they can have atrial fibrillation but perceive a perfectly normal pulse because the pacemaker is driving the pulse, where the upper chambers of the heart are still fibrillating.
Okay.
What does a patient feel when they're in atrial fibrillation? What would be the symptoms?
The most common thing is just a perception of a fast or irregular heartbeat. Patients can feel frequently irregularity of the heartbeat, but many of my patients feel only a minor fatigue. About half of patients in the United States who have atrial fibrillation don't know they have it because it's been essentially asymptomatic. Some patients have no perception of a change in their heart rhythm.
The procedure we're going to see today is called an ablation. And I think that simply means to get rid of it, right?
Ablation by definition is destroying some kind of tissue. And I frequently call it cautery, which technically it's not. It heats up the tissue to just over 55 degrees centigrade. So it's cooking gently, but with a 3 millimeter catheter tip, and in a we're using a marker inside the heart to warm up the to cause it to change from a active tissue to more inert, more like scar tissue.
Let's look at clip number 1 and describe what's going on. Now, this is at the very beginning, and this would happen at almost any procedure you do, but walk us through what it is that you're doing.
In this clip, we're getting access to the vein in the leg. The vein in the leg is about as big around as the thumb, so it's easier for me to find with my eyes closed. And although I usually don't close my eyes to access it, we put in a needle. Through that needle pass a fine wire, which is what you're watching now, and then take the needle out. Over the wire, we then pass the IV, and in this case, I needed at least 3 IVs on one side, so we put in 3 wires, and we'll put in 3 in essence that are the tubes with a port on them through which we can pass the catheters.
So what you're doing is creating an avenue so that you can get up into the heart.
That's the access.
The access, okay. So you're going to go in on the other side as well, too? Because don't you have to get a little camera up there as well?
There are several different kinds of catheters. On the left side, I put in a diagnostic catheter that goes into a specific area in the heart called the coronary sinus. And that allows me to monitor and record the electrical signals in both the atria and the ventricles.
Okay, so there you're going in the left side. And
all of this is through the veins, it's not through the arteries.
I tell patients it's kind of like poking a hole in a drain instead of a supply line. It's usually a lot less messy. So when the needle goes in, there isn't enough pressure in the vein to cause bleeding back through the needle, and so I'm testing through the syringe to make sure that I'm in the vein. That's why you see that the syringe draw back a little flash of blood to make sure that I'm in the lumen of the vein.
Now this patient is asleep under general anesthesia, right?
Yes.
Okay, sometimes I notice that in some of the cath lab procedures, the patient's is sort of in a twilight, aware that something's going on, but not really feeling any pain. But in this case, he's really dead out.
Well, historically...
Don't use the word dead.
I'm sorry.
He's asleep. Historically, catheter-based procedures were done with patients awake. We provide sedation to improve comfort, more for the patient than for the operator. And in the AFib ablation, because the procedure is a little than a lot of the procedures we do, we have the patients under general anesthesia so that they are comfortable lying flat for as long as it takes to finish the procedure, which is coincidentally decreasing every year. When I first started doing AFib ablation in 2002, 2003, in that time frame, it was a 6 or 8 hour procedure. Now we schedule 2 hours of my time for it, and usually it takes less than that.
Yeah, and the reason is because you have technical breakthroughs that have made it easier for you to find out where the AFib's coming from. Is that right?
It's kind of like using a butter knife for a screwdriver and somebody hands you a screwdriver. I mean, the tools get better every year. It becomes much more streamlined. What we're doing functionally is the same as we were doing 5 or 7 years ago. The tools have made it easier not only to do the procedure, but to know when we're done.
Okay, so let's go up to clip number 3. And by now you're actually guiding a catheter. I think you're guiding it up to the heart, aren't you?
I am. This is an ultrasound catheter, and it has, in a sense, an ultrasound camera in the tip. The ultrasound array projects essentially a slice of the heart, and on the screen you can see the tricuspid valve in the right ventricle As I rotate the catheter through the heart, you can see the aortic valve there to the right.
I see valves moving, yeah.
And then beyond the aorta is the septum, and that area of the thin part of the septum is where we'll cross to the left atrium to do this left atrial procedure.
And what are we taking out of the package?
This is a coronary sinus catheter. It's a catheter that has 10 electrodes on it. It's about as big around as a spaghetti noodle, but allows us to record at 10 sites inside the heart from a single catheter and record those channels simultaneously. And there in the bottom screen, we see surface electrograms as well as a series of electrograms from inside the heart. And during the procedure, we can record from as many as 128 channels inside the heart if we needed that many for this procedure.
Goodness gracious. Now, is what you're putting, later on we're going to see some color mapping of the heart. Is what you're putting in there now allowing you to get?
Coronary sinus catheter provides a reference, electrically speaking, and from a timing standpoint, and the ultrasound catheter helps us create geometry to create a three-dimensional model of the heart in real time, which is what we're doing now, and take those images before we go there. So in a sense, before we cross over to the left atrium, as we are now, we can create that three-dimensional model. That three-dimensional model indicates where the four pulmonary veins are. The veins that drain the lungs are represented in that light blue color. And the pink is a left atrial appendage, a structure that we want to essentially respect and avoid if we can.
So where is this arrhythmia coming from when you look at that heart? Is it coming from all around, or are there just specific targets that you're looking for?
Atrial fibrillation is generally regarded as having triggers within the pulmonary veins. Those four veins that drain the lungs. The blue
parts, okay.
Sites in those are veins that plug into the back of the heart. The transition from vein muscle to heart muscle, and of course these big veins have a muscle sheath around them. The transition from vein muscle to heart muscle is not precise, and think about triggers for atrial fibrillation being areas where the vein muscle that squeezes constantly interacts with heart muscle that beats once a second, and where those interactions take place, funny things happen, including triggering atrial fibrillation.
Now, can that happen to anybody, or does my lifestyle lead me to, in some ways, to be more prone to atrial fibrillation than somebody else?
All of the above.
Okay.
You know, I tell patients that atrial fibrillation is caused by who you picked as parents. Some lifestyle choices, high blood pressure, sleep apnea, obesity, all increase the risk of atrial fibrillation, and alcohol can contribute to it. Patients who have atrial fibrillation young more frequently have some genetic contributor to causing atrial fibrillation, sometimes an electrical abnormality in the heart that triggers atrial fibrillation in younger people. And in older people, we frequently just see kind of progression of all of those risk factors contributing to the problem, and we see atrial fibrillation show up in an older population as well.
Now, if we look at the next clip, I think we're going to get to the point where we actually see some of the magic happen here, because this radioactive tip of the catheter you're going to start using, and I think we're going to see some results. So describe to us what we see.
So what you're looking at is cautery in the left atrium that's around the left inferior pulmonary vein.
Which side of the screen are we looking at?
Both technically.
Okay.
They are two images of the same thing, and they're 90 degrees from each other. One is looking from the back of the heart toward the front, and you can see the circle at the top is the back of the model's head. On the left image, you have the veins coming in from the back, and the green dots are the eyeballs looking to the left. The catheter is at the bottom of the left inferior pulmonary vein as we literally draw a circle around the vein. The mapping system records the left atrium, the left atrial veins, and also, as we're watching, it records how long radiofrequency energy, that cautery, is applied in any site. So the ablation of the left atrium is recorded in real time, but it also allows us to look back at the images and say we were in a specific site for 10 seconds applying energy. We were in other places for 12 or 15 seconds recording or applying energy. And we can adjust the parameters to see where we have a spot that we might need to address a little more or a little less. And frequently at the end of that circle, we can predict where we missed a spot by adjusting the parameters to say, oh, look, that's a spot that we didn't spend as much time and use as much energy in.
You're in this next clip, Mark.
I'm watching. Let's go ahead and see what happens next, because I'm asking him a question here, because we're just about finished, aren't we, Doc? And I think you're sort of like checking to see if you've got all the culprits taken care of.
Yes, that round catheter inside the left atrium records electrical signals on 20 electrodes. And that catheter is looking at the electrical activation within each of the 4 pulmonary veins. We'll move it from one to the other to prove that the veins are no longer electrically active simultaneously with the heart. And we pace the left atrium to pace near the heart to activate electrically the left atrium and to prove that the veins are quiet. And in the lower image you can see that occasionally the vein will fire on its own, completely independent of what's going on with the heart, and the heart's beating along quite happily, ignoring what's happening in the vein. The definition, or the sine qua non, of AFib ablation is entrance and exit block from those 4 pulmonary veins. So we don't want electrical signals to go into the veins from the heart, and we don't want electrical activation inside the veins to trigger an activation of the left atrium or the rest of the heart.
Now, we just saw the ultrasound image there. Was that telling you anything?
I was looking at the end of the procedure to make sure there's no problem related to our procedure. We look at the left ventricular function, at the heart function, make sure that there's no fluid around the heart, that there weren't any problems related to bleeding caused by the procedure. And the nice thing about using the ultrasound at different times during the procedure, we leave that catheter on recording the images so that if there's ever a problem, we can usually catch it very, very early.
Now, I heard, I don't know if this is true or not, but I heard that docs that do electrophysiology as you do use the ultrasound a lot more to locate, and you use the digital heart mapping a lot more. Is that rather recent that the younger doctors are using that more often?
Well, ultrasound is a technology that doesn't involve radiation. It doesn't involve X-rays. And in a sense, once you use it for the procedure, any additional use during the procedure is already covered in it. It's free. Radiation to a patient is something that I try to minimize, and obviously all of us in medicine try to achieve as low as reasonably achievable. What I found is that relying on ultrasound to do most of the imaging allows me to avoid using the radiation associated with X-ray. The same procedure could be done completely with X-ray and not using ultrasound at all, and that's the way we did it 10 years ago. I think the ultrasound technique is catching on, and the idea of minimal fluoroscopy is an idea that's catching on, reducing fluoroscopy exposure, reducing radiation exposure to the patient, and we could count that in how many chest x-rays it takes to do the procedure. Most of my procedures are done with a very minimal amount of radiation, in part because that's just the habit I've gotten into, but also because that's been a goal to push the envelope, as it were, in terms of improving the experience, even if a patient's asleep at the time and don't realize that they have some radiation exposure.
Okay, now you can correct me, Dr. Mishkel. I need correction on what is atrial flutter and what is atrial fibrillation, because I've gotten them backwards before.
Right.
Go ahead and help me.
Well, I'm going to turn that over to Dr. Scherschel to tell us the difference between atrial fibrillation and atrial flutter.
Atrial fibrillation is electrically very much like raindrops on a pond. If you look at the electrical activation of the heart in normal rhythm, it progresses very uniformly from the pacemaker of the heart through the atria, just like a flash. Atrial fibrillation is literally hundreds of sites around the heart, around the atria, firing in essence simultaneously. It's very disorganized. And if you recorded an electrical signal at any site in the upper chambers of the heart, you wouldn't be able to figure out where it's coming from, which direction it's going. Mm-hmm. And atrial flutter is, in essence, a racetrack rhythm. It's a rhythm where the electrical activation, instead of going straight from one side to the other of the upper chambers, makes a detour and makes a loop. And if you look at it, it's a racetrack going 300 times a minute around the heart frequently, which causes fluttering of the upper chamber.
If I have AFib and I don't get it corrected, what risk do I run?
The number one risk is stroke. Atrial fibrillation historically has been difficult to treat, but from a medical standpoint, we worry more about stroke than how miserable you are with the rhythm. As we've gotten better at being able to treat atrial fibrillation, we can focus more on the symptoms. But the number one rule for patients with atrial fibrillation is don't have a stroke. Patients who are at higher risk for stroke, we put on blood thinners. Mm-hmm. And patients who are at especially low risk for stroke, we say that the risk of the blood thinners is higher than the risk of the stroke without them. And so there is a population who doesn't require anticoagulation, blood thinners, for reducing the risk of stroke and atrial fibrillation.
When a patient comes to you and has an AFib ablation, oftentimes they'll come to you and say, I want the AFib ablation because I want to get off the blood thinners.
And I say that's the wrong reason to do an AFib ablation. Typically, if we do an AFib ablation, there is a recurrence rate. And that recurrence rate in the first year is the highest. After the first year, it drops down. And if you look at long term, there's a risk of atrial fibrillation recurring. If a patient has especially high risk for a stroke in the context of atrial fibrillation, I would say it's unlikely with the procedure we would be able to get them off the anticoagulants. If a patient is kind of lower risk or intermediate risk, I tell them it really depends on how sure we are that the coast is clear. How sure are we that AFib is gone? And usually that requires waiting a year or two after a procedure to see, okay, what happened in those 2 years? Did they have any AFib at all? If they had any extra heartbeats or palpitations, were they aware of it? And what is our assumed risk if we keep someone on a blood thinner at that point? And what is the risk if we stop it? Occasionally, we are able to stop blood thinners in patients and say, if you have another bout of AFib, start back on your blood thinner and then call me, and we'll figure out what to do from there.
Now, let's put in our minds again the vision of that heart, that green or that blue and pink heart, and those little red circles that you had ablated all around there. What causes that little red circle? Is it like a wave or a microwave? It's something that provides a very sort of gradual heat. Is that right?
It does in a sense. The ablation contact site where we have the catheter placed is heated up by a radio frequency energy that's in a sense like microwaves that only penetrates about 1 millimeter. We warm up the tissue about 1 millimeter away from the tip of the catheter, and the catheter itself is cooled. So we don't worry about char forming on the catheter. We worry about it forming a clot at the tip of the catheter because the tip of the catheter in essence looks like a colander with tiny little holes where fluid flushes the tip of the catheter, and it warms up the tissue inside the wall of the heart. That tissue is warmed up to the point where it is in essence medium rare. It's cooked slightly, but only within a radius of about 1 millimeter of the tip of the catheter. So those dots you saw were represented as 2 millimeter location points. That is about the diameter of the tip of the catheter. The actual damage around the tip of the catheter is slightly wider than that. But it's a good reference to think that the heart is blown up on the screen, and those dots that you see that are about the size of a finger point are actually 2 millimeters in diameter. So the area that we're cauterizing is very small, but it's the radio frequency energy, and it's best explained as a kind of microwave that warms up the tissue without warming up right in front of it.
Is it accurate to say that you're creating scar tissue in there?
Scar tissue does form usually long after the procedure. We aren't creating scar tissue immediately, but we wait as things heal and scar tissue will infiltrate that area.
Do you want to be an electrophysiologist now?
Never.
Being a plumber is just fine with you.
Being a plumber was fine. It's it's pretty sophisticated stuff. The what John does with the marrying the ultrasound with the mapping
Yeah.
system and avoiding radiation is really magical for somebody who has been used to doing everything under fluoro. Really, the ability to move around just and rely on ultrasound and feel comfortable relying on the ultrasound rather than on the X-ray. Really, I think a huge advance. And so I think as I see generational changes within our practice, we're going to see more and more reliance on these non-radiation based imaging facilities.
I know the procedure I was in on, we were in for maybe 15 minutes. You took a couple pictures, and then you said, "Okay, get rid of the lead. That's all we're going to do with the or what's it called now? The
X-ray.
X-ray. That's all we're going to do with the X-ray." So, and that was it. That was it. Well, listen, thank you both for coming in. It's been terrific, and
Thank you,
Doctor. Doctor, it's wonderful learning about the difference between AFib and atrial flutter. I'm glad I got corrected.
Racetrack and raindrops on a pond.
Thank you both.
Thank you.
And thanks to you, the audience, for watching Cardia. We'll see you next time.